Welcome again to the Oral Health Screening in the Primary Care Setting webinar. We will begin shortly. Good afternoon or good morning, depending upon where you are joining us from. Welcome to the Oral Health Screening in the Primary Care Setting webinar. Dr. Mofidi, HRSA Chief Dental Officer, is the chair and moderator for this event. I will now turn the meeting over to Dr. Mofidi.
Good afternoon and good morning, everyone. It gives me great pleasure to welcome each and every one of you to this webinar on oral health screening in the primary medical care setting for persons living with HIV/AIDS. We've had a tremendous response to this webinar and have reached our capacity for 250 participants. I would like to remind participants that this webinar will be archived for later viewing for colleagues that were unable to attend. This webinar today is sponsored by International Antiviral Society USA, and continuing medical education credits are available of up to 1.5 hours. Please listen to this training via your computer speakers. Make sure that your computer speakers are turned on and volume is adjusted. If you are having any technical problems, please contact Jenna Bardwell at kahjm@umdnj.edu or pose a question in the chat box on your screen. For any additional troubleshooting information, they can be found in the email reminders that were sent out on Monday and earlier today. For participants who are intending to claim CME credit or who want a certificate of participation, logging in with your name will verify your attendance. If you are among a group, please make sure that one contact submits a list of all participants with the chat feature to ensure that all receive credit. When the webinar is completed, please fill out the evaluation form as well as the CME claim form. The links for these can be found in the email reminder that was sent earlier today. And your feedback is very important to us, so please take a few minutes to complete the evaluation. Throughout the webinar, we will be asking polling questions as a way to get to know our audience better. A separate window with the question will display at the center of your screen, your computer screen. You can choose your response within 10 seconds, and the totals will display after you have voted. So we have our first polling question.
All right, the poll is now open.
So the question is, what is your clinical role? Primary medical practitioner or a health professional, administrator, or other?
Okay, the poll is now closed.
Okay, looks like as of right now, we have 40% of our participants are oral health providers and 14% of our participants are primary medical practitioners. We have another polling question for you.
All right, poll 2 is now open.
This asks, how are you viewing the webinar?
Okay, the poll is now closed.
It looks like most, over 80% of all people who are viewing this webinar are doing it individually. So this is our agenda. We have an exciting, aggressive agenda for today. I want to briefly go over the timing. We will start with an overview of oral health screenings and a 5-minute question and answer period. Next, we will have a testimonial of one physician's experience in overcoming barriers to oral health screenings in routine visits. That will be followed by another question and answer period. And that will be followed by a case-based talk that will illustrate how attention to oral health made a difference in a patient's overall health. We will wrap up the webinar with a final question and answer period and a summary of the program. We need to provide this information for CME purposes. Drs. Mofidi, Hill, and Van Wagner, and Ms. Richardson have no relevant financial affiliations to disclose. And in terms of the target audience today, this course is primarily designed for AIDS Education and Training Center clinicians and Ryan White primary care medical care clinicians. And the objectives for today's webinar are to describe the impact of oral disease in people with HIV, perform oral screenings on HIV-infected patients, and describe strategies for linking patients with HIV to dental care. We have one more polling question.
All right, poll number 3 is now open.
This is designed specifically for the primary medical practitioners. I think we need to have the poll back on the screen.
All right, sorry about that. Poll 3 is now open.
And just for the primary medical practitioners.
Okay, the poll is now closed.
Well, it looks like, over 40% of all the medical practitioners, providers who are on this webinar do perform oral health screenings either regularly or sometimes. So we will now start with our presentations, and I would like to draw your attention to the U.S. Surgeon General's report on oral health published in 2000. The overarching message of the report was, you cannot be healthy without oral health. The mouth is an open door to our overall health. The report under Dr. Satcher recognized that oral health is essential to overall health and quality of life, and that all families need access to high-quality dental care. Despite the importance of oral health, there is mounting evidence of unmet needs for oral health care among those living with HIV/AIDS. For many years, our Ryan White program clients have consistently reported high rates of unmet oral health care needs and low utilization of oral health services. The populations we serve have more unmet oral health care needs than the general population. They also report to have more unmet oral health care needs than unmet medical needs. And finally, certain groups of people living with HIV/AIDS, such as people of color, especially women and those without dental insurance, are less likely to receive oral health care than others living with HIV.
Dr. Mofidi, I'm sorry to interrupt, but could you possibly try to speak a little bit louder? I think some participants are having trouble hearing.
Okay. So why does, is this better? Yeah. Why does good oral health matter in HIV/AIDS? Persons with HIV experience a high incidence of oral health problems such as dental decay and gum disease, but also other problems that are directly related to HIV. These include fungal, as well as neoplasms, lymphomas, and oral ulcerations. Many of these problems manifest themselves more in HIV than those without HIV. And recent studies show that between 32 to 46% of positive patients will have at least one HIV-related oral health problem in the course of their disease. And this proportion represents actually an improvement from 1990s when it was around 80%. The introduction of highly active antiretroviral treatment changed the epidemiology of some of these opportunistic infections in the mouth. Notwithstanding this decline, some of these oral health problems are painful and aggressive. In addition, their identification in a healthcare setting is a marker for HIV. It may signal the progression of HIV or suggest a failure in therapy. Now, in addition to these oral health-related manifestations of HIV, we're still seeing a high prevalence of dental caries and periodontal disease. Why do we care about treating these infections as quickly as possible? Because with a diminished immune system, a small cavity or gum lesion can quickly turn into something major like an abscess. And one reason for the high occurrence of dental decay and periodontal disease is decreased salivary flow or dry mouth that is brought on by the disease itself or the use of HIV medication. Another important point about why oral health matters is that oral disease is rarely self-limiting. Poor oral health impedes food intake and nutrition that can lead to poor absorption of HIV medications. Bacterial infections such as dental decay and periodontal disease that begin in the mouth can escalate to systemic infections and inflict damage to the heart and the brain and other organs if not treated. And there's strong association between periodontal disease and heart disease. A history of chronic periodontal disease can disrupt diabetic control, and studies have shown that pregnant women who have periodontal disease may be 7 times more likely to deliver preterm low birth weight babies. And finally, poor oral health can adversely affect quality of life and limit career opportunities and social contact. One solution for improving access to oral health care and reducing oral health disparities is to integrate oral health in primary care medical settings. HRSA has identified the expansion of oral health and its integration in primary care settings as one of our strategic priorities. Why is involving medical care providers so important? Well, Medicare providers may often be the first provider that a person sees after an HIV diagnosis. Patients may often visit primary care providers well before visiting a dentist, and this presents a valuable opportunity for medical providers to deliver early oral health preventive services. This makes sense given that oral health is a key factor in the overall health of people living with HIV/AIDS, as evidenced by having oral health as one of the core medical services under the Ryan White HIV/AIDS program. And support for engaging medical providers in oral health care also comes from the Surgeon General's report on oral health, as well as a recent Institute of Medicine report entitled Advancing Oral Health in America. All primary care providers can contribute to improve oral health. Interprofessional team-based care has the potential to improve care coordination, patient outcomes, and produce cost savings, according to the IOM report. Many non-dental care professionals are well suited and willing to integrate oral health care delivery into the primary care settings, but are not trained to do so. And non-dental healthcare professionals have a significant role to play in oral health promotion and disease prevention. Key modalities include basic examination and risk assessments, which is the topic for today. And finally, there are clear benefits for integrating oral health in primary care. They include earlier linkage to oral health care, reducing avoidable complications, reducing burdens and economic costs associated with preventable diseases. And as we integrate oral health in medical care, this conveys an important message that oral health needs to be seen as a common agenda affecting healthcare providers, our patients, and policymakers. So with this background information in mind, let's go ahead and introduce our first speaker, Dr. Jeffery Hill. Dr. Hill is an associate professor at the University of Alabama School of Dentistry. He is the director of the 1917 HIV/AIDS Dental Clinic and has been active in HIV medicine for more than 13 years. Dr. Hill?
Thank you, Dr. Mofidi. I'd first like to do a brief overview of what we're going to be talking about today. Our main point, of course, is to provide information on how to perform a thorough but quick intraoral examination. And by quick, I mean that initially, until you get comfortable with it, maybe 2 to 3 minutes to go through a complete exam. And then after that, once you become more comfortable with your systematic approach to doing the exam, maybe break it down to about a minute or a couple of minutes, depending on if you find anything in there that needs a little further investigation. We will also, as we go through the exam, talk about a few common oral lesions and some normal variations that we may see along the way. We're going to be talking about soft tissue and the teeth and gums. We'll be talking about a few key anatomical structures that will help us identify some things, and basically just a way to separate the normal and the normal variations from what might be abnormal. And also then near the end, we're going to talk about linkages to oral health care providers from primary medical care providers and some information on that. So first we're going to go through the exam. We would need, of course, a good light source because you need to be able to see very well. We're going to be doing exams where we want to see everything possible and also be able to feel as much as possible. So we're going to also use a tongue depressor. An intraoral mirror would be better. That's one of those small little mirrors that the dentist uses to look around your mouth. You can actually get those in large quantity packages, little plastic disposable ones that are fairly inexpensive. And then some 2x2 cotton gauze and, of course, gloves. We're going to use a systematic approach. There's nothing magic about the approach that I'm going to lay out here. I just think that doing it in a systematic way helps us to remember to find everything, look at everything, and hopefully not forget to look at some things. And we're going to use a combination of visual inspection, be able to see stuff, and some palpation, whereas if we're checking out some tissue that is bound to the bone or against a bone, we'll use compression, where you just push with your finger and press it against the bone. And we'll also use some bidigital palpation, where you actually get the structures between your fingers and feel of them. So first, we'll want to take a look at the lips. And this can best be done actually when you're initially talking to the patient, just in the initial interview maybe. You'll be observing the lips and their shape and color and texture. And you can also look for symmetry. If the patient has like a deviation to one side, or it looks like they're still numb from coming from the dentist, then that could indicate that there may be some nerve damage or some palsy of some type, post-surgical, post-herpetic, that sort of thing. We'll want to examine the vermilion border. Let me see if I can click on my arrow here and drag it across. The vermilion border is, my arrow doesn't seem to be working. But anyway, the vermilion border is the area where the facial skin meets the skin of the lip, essentially. There we go. Now it's working. Sorry about that. So vermilion border would be right along here. And on the lower, it'd be right along here. So that's the vermilion border. We want to check that out, make sure there are no lesions there. Everything should be nice and smooth. Some common things that you might see in that area could be herpes labialis, for instance, is commonly seen right along the vermilion border there. And then we're going to pull on the lip gently and kind of stretch it out a little bit so that we can view the wet-dry line. And it should be fairly obvious where we go from the dry mucosa over to the internal wet mucosa right along in this area. And so this vermilion zone that's out here is an area that is prone to sun damage. And so if you live in a bright sunny area and get lots of sunshine, then along the upper lip here and the lower lip down here, you could see some sun damage that might lead to actinic keratosis, for instance, which would be kind of a persistent, dry, scaly patch. Those, I think about maybe 5% of them can go on to be skin cancers. So if it's more than just chapped lips and it's been persistent, then you might want to have that investigated a little bit further as well. And then angular cheilitis we see fairly commonly. It will be at the corner of the mouth, right where the lower and upper lip meet. It may be unilateral or bilateral. It is actually a fungal infection, and you'll see some inflammation there, maybe a little bit of crusting, some scabbing, and sometimes you actually see a little bit of mounding or heaping of the tissue with a little bit of a pseudomembrane in between those places. So that is considered a fungal infection, and it should be treated with a topical antifungal as opposed to just chapstick or something like that, because it won't go away with just that. So if the patient says, yeah, this has been here for a while, I've been treating it with moisturizers and so forth, then it's probably just a little fungal infection, and then they can get that treated with a little topical antifungal. Then we're going to move on to actually feeling of the lips. So that if you get the bidigital palpation here, so you just gently pull the lip between your fingers, and you want to feel all the way from side to side, and you want to do the same with the upper lip. And what you'll feel inside there, the lip should be firm but pliable, and you'll feel slightly nodular in between your fingers. And those will be the minor salivary glands, and there'll be lots of them in there. And so what you're feeling for is if there are any of them that seem to be larger than the others, or if they're tender to the patient, something like that. So be expecting to feel some nodules in there, but they should be fairly consistent, and they're minor salivary glands. Some common things that we see inside the upper and lower lips would be mucoceles, which is a clogged salivary gland. So if you feel a bump in there and you pull the lip back, what you would expect to see is sort of basically a clear bubble. But you'll note that the clear bubble is coming from underneath the mucosa, and it's pressing up and stretching the mucosa out. So that's just the clogged salivary gland. If you just pop it, it'll probably go down, but it most likely will come back. So they actually need to be excised. The whole gland needs to be excised to be able to get rid of it entirely. A variation of that is when a blood vessel gets twisted and tortured around and dilated, and that's called either a varicose or a thrombosed varix. It'll be essentially the same, a larger nodule, except instead of being a clear bubble, it'll be more of a reddish to dark blue, purple kind of a bump inside there. But the same thing, it's a clogged vessel, the blood can't get through, so it swells up and it needs to be excised. Some external lesions that we sometimes see in this region would be an irritation fibroma, which is just excess tissue caused by the irritation, sometimes from either a malaligned tooth or maybe a chipped tooth or something that's just rubbing on the tissue. Could be even, chronic lip biter could also get a fibroma. Those are usually about the same color as the surrounding tissue and nice and smooth and glistening. It's just like a lump of extra tissue. If the patient's been chewing on it, there could be a little bit of hyperkeratosis there, so it'll look a little bit more whitish. But just extra tissue, a lump, usually not on a stalk or anything like that. And then we also see sometimes papillomas from the human papillomavirus. Those can be either broad-based or they could be on a stalk. And the easiest way, I guess, to tell the difference between a papilloma and a fibroma is the surface texture, because most of the papillomas will be kind of rough and grainy. They have more keratin in them, so they're a lighter pink or maybe even to a whitish. And sometimes the rough texture to the outer surface could even be sort of sharp and spiky as well. So that would be a papilloma from the human papillomavirus, and the patient would need to be informed that they do, have a virus. Of course, you need to do a biopsy and get that all confirmed just to be sure, but you inform the patient that they do have a virus that's circulating throughout their body. There's a high recurrence rate with papillomas. Doesn't necessarily have anything to do with their HIV status or their T-cell count or anything like that as far as we know. They just kind of come and go on their own. We do pay a little bit more attention to these, not because the papilloma itself is precancerous, but the patient that was exposed to the HPV that caused wart may also have been exposed to some of the types of HPV that cause intraoral cancers. So that would up their risk factor a little bit by having intraoral papillomas, so we would pay a little bit more attention to that as well. So moving on. So if we look underneath the upper lip, of course we want to feel the upper lip as well, and then we're going to just lift the lip up and look underneath. You'll notice the labial frenum there. There's a maxillary and a mandibular. So that is, let me get my green arrow back here. Well, can't find it, but anyway, I'll see if I can grab it. There it goes. So that'd be the frenum right there. That just holds your lip down. And here's the main one here, but there are others off to the side as well. Sometimes those can get injured, but usually you don't have much problem with the frenum. If you pull the lips back, you should see tissue that is smooth and glistening. You'll see it's highly vascular, so you can see a lot of little blood vessels in there. Another thing that you might find, especially in areas like right around the side here, you may see ectopic sebaceous glands, and they're called Fordyce's granules. And people may have these their whole life and never notice them, and then just one day they're looking in the mirror, and they all of a sudden see these and think that they've, got herpes or they've got cancer or something. So if they come in and start asking you about those, if they basically look like little grains of sand underneath the mucosa, and they're not palpable, you can't really feel them, but they just look like little clusters of sand grains underneath the tissue, little whitish, yellowish color to them, then it's most likely those little sebaceous glands, Fordyce's granules, and they're innocuous. They were probably there before, and the patient's just now noticing them. If we move on to talking about, if we reflect the lip back and we gently pull it from side to side like this, you can see how the tissue swings over to the side. This area right along here, it's a little bit scalloped along there, is called the mucogingival junction. And that's an anatomical landmark that I want to point out because it has some important implications. Not only does it make it easier for you to communicate if you're trying to describe where there's a lesion and you're trying to describe that to an oral medicine or oral pathologist, you can say it's, above or below the mucogingival junction and so forth. But another thing is it will narrow your differential for intraoral ulcers. This mucogingival junction goes all the way around, so it's right below the teeth, usually a few millimeters down, and all the way around. On the lower, it's going to go all the way back around the back of the molars, and even if the teeth aren't there, it still goes all the way back behind where the molars should be. And then it horseshoes around just on the other side of the lower incisors. So the lower one is sort of like a horseshoe. On the upper, it goes in the same general region, except it also includes the hard palate. So I'll point out later the junction of the hard and soft palate is where the mucogingival junction is up in the hard palate. So above the line here, where it's bound down to the bone, is keratinized. Below the line there and out onto the lip and into the cheeks is non-keratinized, non-bound tissue. So if the patient has an ulcer out here on the non-keratinized, non-bound tissue, then your best guess is going to be that it's an aphthous ulcer. If the lesion is on the keratinized or bound to the bone tissue, your best guess is that it's going to be herpetic. If you're talking about traumatic ulcers, they can occur anywhere. So they can be anywhere in the oral environment, but they usually take the shape of whatever caused the trauma, so like a burn, for instance, or a stab wound from a fork or chips or something like that. Most common in the palate, but still it'll look more like that. The herpes lesions and the aphthous ulcers are usually fairly round. The herpes lesions on the bound down tissue will be red in the center and will have sort of a whitish yellow halo around them. And then the aphthous ulcers out on the non-bound tissue will be red around the outside with a yellowish, grayish, whitish internal pseudomembrane. So that's just kind of a quick and easy way to determine between herpetic ulcers and aphthous ulcers. So if we look into the cheek tissue, you want to pull that out, stretch it out a little bit, and look around inside there. Again, soft, smooth, glistening, moist. You may see a little bit of hyperkeratin along the line between the upper and lower teeth. That just represents a little hyperkeratosis, a little thickening of the tissue. That's called linea alba. And then leukoedema, if you see sort of a bluish opalescence, that when the tissue is relaxed, it looks kind of spiderwebby, but when you stretch it out, that goes away. That's probably leukoedema. It's innocuous, normal variation. And then also there is the exit to the parotid gland, which we're going to look at again here in just a minute. Now, if you see white lesions back here and the patient doesn't have any teeth, that would throw up a red flag. Because if there's hyperkeratosis and the patient doesn't have any teeth and can't bite their cheek, then something else is going on and warrants more investigation. You can also use bidigital palpation to investigate the parotid gland and Stinson's duct. If you get the gland between your fingers, you need to reach all the way back as far as you can with your finger and kind of up by the upper molars. Just feeling for any tenderness that the patient may feel. If you feel any firm nodules in there, it could be an indication that the patient may be having some salivary gland disease. If it's unilateral, it may indicate a salivary stone. If it's bilateral, then it's probably something more systemic than that. Here in the lower picture, we have a closer-up version of Stinson's duct. It should be sitting right opposite the upper molars. A couple of conditions there would be sialidinitis, and that's just inflammation in the gland itself, probably caused by some sort of infection or something in there, maybe a bacterial infection. And then sialolithiasis is actually when there's a stone blocking the exit here. And so either of those would probably need a referral to an oral path or oral medicine doctor. Sometimes the stones can be coaxed out with some sugar-free tart candies like lemon drops or something like that. Just stimulate the salivary flow and the stone may be flushed right out. If we look at the hard palate, then let's see, right across here is the area I was talking about with the mucogingival junction. So behind that will be non-keratinized tissue, and then anterior to that is keratinized tissue. So this is bound to the bone here, and there's the dividing line right there. You can even see a difference in the color. The soft palate has a little bit more of a yellowish, whitish hue to it, and then the hard palate is a little more pink. This is an area that we may see really thick keratinized tissue on the hard palate, which may indicate smoker stomatitis. If it's someone who smokes heavily, then they may see increased keratin here, and you may also see some of the exits to the minor salivary glands getting really irritated. So a whitish area with little red dots could indicate heavy smoker stomatitis. The incisive papilla this is actually me looking in my intraoral mirror at the back side of the upper teeth, but there's a little bump right behind the upper incisors called the incisive papilla, and that's a very common place for trauma. Either eating, or if the patient has a deep overbite, they may actually bite on it. So if you see that and it's red and inflamed, then first investigate if they've injured it somehow. If they don't bite on it and they haven't injured it somehow eating, then there's a possibility there could be a little infection under there, or maybe even a cyst in the canal that lies right under that papilla. The rugae are just past that. These are just those sort of ridges that you feel in the anterior region. And then I wanted to point out, this is a stone model of a patient with a palatal torus. This is not a tumor, it's just a big lump of bone in the center of the palate. And if you put your finger up there and press on it, it should be covered by hard keratinized tissue, and it will be very firm and solid. And we see that a lot in patients who are heavy bruxers and grinders. But if you were to see something, a big lump in the patient's roof of the patient's mouth, and you felt it with your finger and it was really soft and squishy, then they may have a tumor, so you would need to get them a referral. Soft palate, thin, non-keratinized, very vascular. It's movable. When the patient says, ah, it should raise up. Common place for intraoral candidiasis with the white curdy things that can be wiped off. The palatine fovea are these little depressions at the junction of the hard and soft palate. So if you see little depressions, dimples in there, that's normal. And have a glance at the uvula and the tonsor pillars while you're in there. Tongue depressor, tongue down, and have a look around just for any inflammation, any exudate, that sort of thing. We're looking at the top of the tongue. Median lingual sulcus, there is a such thing as a fissured tongue, which is cracks and fissures in it. I'm not sure what just happened to my screen. I'm sorry, I'm having trouble with my screen. I'll just keep talking. Maybe I didn't affect everyone's screen, because now I can't even see my little chat box.
Dr. Hill, if you would let us know to advance your slides, we'll do this from this end, and you can keep your presentation going.
Okay, so everyone else is seeing it fine?
Looks very good.
Okay, all right, then I am moving on. So I was talking about the tongue there. Something fairly common is median rhomboid glossitis, which is just a thin, a red patch in the middle of the tongue where the papillae have denuded, and that could indicate a type of oral candidiasis called erythematous candidiasis. And then you'll see some papillae on there. There are multiple kinds. Sometimes the filiform papillae, which are the little hairy-like papilla, will grow out, especially in relation to, oh yay, my screen's back, in relation to smoking. Smoking can cause the papillae to not desquamate the way that they should, and so you could get this condition called a hairy tongue or a brown hairy tongue. And then geographic tongue is when there are red patches sort of scattered about the tongue with sort of white rings around them, whitish yellow rings around them. And it also is innocuous, except that sometimes it's very irritating to the patient. So I usually just ask them to tone down their diet with less spices in their food and that sort of thing until it gets better, because it usually gets better on its own. So if we look underneath the tongue, very thin mucosa. If you see a lot of splotchy areas in here with varicosities and that sort of thing, it could indicate that the patient's having trouble with some hypertension. Otherwise, we'll just note the lingual frenum there, holding the tongue down. If we look at the lateral borders of the tongue, we can also grab 2x2 gauze and take the end of the tongue and sort of pull it out. And along the lateral border of the tongue is where we sometimes see the oral hairy leukoplakia. So you'll see vertical stripes running up and down the side of the tongue. These you cannot wipe off. It's caused by a virus, and it just causes extra growth of the surface tissue there, so it can't be wiped off. All the way down at the base of the tongue, the very root of the tongue, is one of the more common places for squamous cell carcinoma. So we want to be sure that we pull that tongue out and look all the way down at the base of the tongue and note anything in there that might look abnormal. White patches, red patches, growths, ulcers, anything like that needs to be noted and a referral made if necessary. So more floor of the mouth, it's very vascular, thin mucosa. Also, if you see any little patches of anything that doesn't look normal, then you should investigate that, because that's another common area for squamous cell carcinoma. So anything that looks abnormal, doesn't quite fit the scenario there, should be investigated and referred. Submandibular glands exit actually at the right on either side of the lingual frenum there. And again, that's a common place for salivary stones and inflammation. And the sublingual glands are underneath as well, and their exits are along the sides where those little bubbles are showing up there. And these bumps, lumps that are under here are more excess bone, so they're lingual tori. So that should be firm to the touch there as well. So we talk about the teeth. We have 32 teeth in adults. We start at the upper right and start counting with 1, and we count the ones that are missing as well. Upper left, number 16, drop down, lower left, number 17, all the way around to 32 in the lower right. So just take note if you see, the main thing would be if you see, bombed out teeth that are black and rotten, or you see a lot of plaque and calculus in there, they definitely are going to need a dental referral. If we want to describe the teeth and gums, healthy teeth and gums, the gums should be pink and firm, stippled with knife edge margins, so they should lay really flat. They should be really flat against the tooth. The interdental papilla should be pointed and firm as well. Occasionally you'll see normal melanotic pigmentation with these sort of brown to purplish patches. And then we'll go on and talk about gum disease pretty quickly here. So a couple of major concerns that I've seen over the last several years coming to the forefront in our patients would be dental caries, just decay in their teeth, and periodontal disease. Of course, this can cause pain and discomfort. It carries a heavy microbial load in all those cavities, a lot of places in there for bacteria to hide. See inflammation in the gums. It's chronic inflammation, which is not good for the patients long term. Infection associated with bad teeth and leading to tooth loss, which can affect their overall quality of life, their ability to eat properly, nutrition, and so forth and so on. One main cause of that is xerostomia, or a dry mouth syndrome. This can be attributed to salivary gland disorders. Also medications. There are like 400 and something medications that cause dry mouth conditions. Dietary habits, have high sugary, high carbohydrate diet. Smoking dries the mouth out as well. Alcohol dries the mouth out. Poor oral hygiene, where they don't get regular checkups and cleanings, and they're not cleaning their teeth very well, not flossing every day. And then I also have a picture or two about meth mouth, which is similar to regular dental caries, but a little bit different of a pattern there. But the end effect is the same, and the patient will need a dental referral to try to get their teeth restored. So just a couple, 3 cases here. This is a patient that suffers from a dry mouth. So you see these very typical cervical areas of decay kind of arrested there. They've turned black, but you note the patient has good oral hygiene. There's no soft deposit plaque in there. He has very little gingivitis going on in this teeth. And this is because the patient has a chronic dry mouth. If we look at this patient who has suffered from neglect for quite a while, he had a lot of systemic issues to deal with and just basically did not feel like taking care of himself. He didn't come in for visits. He didn't brush and floss. His decay is different pattern, different look to it, and you can see there's some plaque buildup in there, and he has some gingivitis as well. Swelling, red. If we took a probe and probed this, we would have bleeding going on there as well. So a little bit different pattern from a patient who has neglect and plaque buildup as opposed to a patient who just suffers from a dry mouth. This is one of our meth mouth patients. Still cervical decay. He does have some inflammation, some gingivitis going on up there, some plaque retention as well, but it's concentrated right here in the anterior because of this patient's preferred method for partaking of his meth. His other teeth, lower teeth, and in the posterior are actually in pretty good shape. So this can be directly attributed to his meth habit. But the restoration process would be the same. And we go back to our other patient. I just wanted to point out his gingivitis here and the plaque that he has accumulated along there, because these cavities are kind of hard to keep clean anyway, and he still isn't doing a very good job of brushing and flossing. His teeth are cracked and chipped up along the top because he is also a chronic bruxer. This is a more peculiar type of gingivitis related specifically to HIV patients, and if you'll note that the patient has good oral hygiene, the papillae are still pointed in here, and the tissue is not really swollen, but it is inflamed a little bit erythematous. So you see that little red band around there. And if you could see this really up close, you would see that this area is actually somewhat translucent. So it's kind of like looking through cherry jello, as opposed to our other patient who was swollen, inflamed, and had the darker red even in his papillae that were beginning to go away too. So this is not attributed to the patient's oral hygiene habits. It's attributed to the HIV gingivitis.
And we'll conclude this presentation in about 1 minute.
Okay. Last couple of slides here. This is necrotizing gingivitis. You can see the necrotizing tissue there affecting the papillae. This patient would need an emergency referral to the dentist. This is rapidly destructive, and so we need to get this person to the dentist pretty quickly to get this under control. This is generalized periodontitis. So from gingivitis to periodontitis, it's involving the supporting structures so that they're losing gum, they're losing bone, the teeth are getting loose and mobile in here. This is a lot of calculus buildup, decay in there, and this goes all the way around. You see some spontaneous bleeding there as well. So this patient, although it's a chronic condition, does need a urgent dental referral. This is a localized severe periodontitis, rapidly destructive in here, a lot of buildup in there. This patient lost these 3 teeth because of the destruction in there. But the rest of his oral hygiene is pretty good. So he just got affected right in this area here. And then this patient is going to need a very quick referral. This is necrotizing periodontitis. This came on within a couple of days. Rapidly destructive. These teeth actually were all lost. The tissue was lost. So if you see a patient coming in that has something looking like this, they need to get to the dentist pronto. Okay, so the last thing, all patients need a dental referral. You can go through the soft tissue screening and screen for oral lesions and so forth. You can look at their teeth and gums some and decide if they're going to need, like an emergency care or just preventive care. This is also a good time to emphasize the importance of good oral health to the patient, emphasize the connection to their systemic and overall health as well. Referring to the oral health care provider, You can break the patients down into this patient needs to go immediately, or this patient just needs to go some routine, preventive care. Try to make a link to someone in your area that is a provider and give the patient the information, maybe even help them make the initial appointment so that they can get to the dentist and get things taken care of.
Thank you very much, Dr. Hill, for that presentation. Participants, we have a few minutes to ask questions, and please use the chat box there to pose your question for Dr. Hill. Dr. Hill, can you again tell us how long it takes to do an oral health screening?
I think initially, once you get used to doing one, the first few ones will probably take maybe 2 or 3 minutes. But then after that, once you've done a few and you got more comfortable with it, probably a minute for someone who's not having any problems is sufficient. But maybe up to a couple of minutes if you see something that draws your attention and you need to spend a little bit more time investigating.
Okay, there's a question. It says, what about malignancies such as Kaposi's sarcoma, and any suggestions on head and neck palpitation and signs of asymmetry?
Well, as far as the KS goes, if we were to go back to the slide showing the hard palate, the most common place for KS to show up intraorally early is in the hard palate. It'll be over to either the left or the right, and sometimes bilaterally, and it'll be just above where the molars are. There is the posterior superior alveolar vessels there, the artery and vein are in that area there. And KS is a vascular lesion, so what you'll see there is looks like a little darkened area that looks sort of like slight bruising is what the very early cases look like. As they progress, they get darker and become more nodular. If you see it in the gingiva, which is also another common place, it's going to be sort of a darker purplish red color and somewhat soft and will bleed easily if you probe it.
Dr. Hill, we're going to take one more question, and at the end of today's webinar, we'll come back to address some of these other questions. But quickly, what are the most common drugs that causes dry mouth, perhaps some of these ARV drugs?
Actually, the antiretrovirals don't have a great effect on the oral environment. The most common drugs are those for hypertension, and probably the very most common would be the ones for anti-anxiety, antidepressives, that sort of thing. Those are the ones, those entire classes cause more dry mouth disorders. We don't really have a lot of issues with the antiretroviral medications causing any oral problems.
Thank you, and we'll come back to these questions a little bit later. So next, we want to move on and introduce our next speaker, Dr. Nicholas Van Wagner, who is an assistant professor at the University of Alabama School of Medicine. And Dr. Van Wagner will talk about his experience of overcoming barriers to providing oral health screenings at his clinic. Dr. Van Wagner?
Thank you, Dr. Mofidi. I really appreciate the opportunity to be able to talk with you today, and I would like to thank both AETC as well as IAS-USA, in addition to Dr. Mofidi, for this opportunity. My purpose today is, in essence, to offer a testimonial in addition to some of the lessons that I've learned about the importance of oral health screening in the primary medical care setting. And so my job at UAB is just that. I provide primary care to HIV-infected patients at the 1917 clinic, and I've done so for about 6 or 7 years now. So I'm going to talk basically about two things. And first of all, some of the obstacles that we face as primary providers that may interfere with our ability to perform good oral health exams. And then some of the lessons that I have learned that have been helpful to me in helping me continue to perform good oral health screenings. At least I hope good oral health screenings. So the problem that we face as primary providers in HIV is that we have so many problems that we have to take care of and so little time. In addition to taking care of a patient's HIV, we often are their primary care provider. Sometimes we are their social worker, their life coach. We help them with substance abuse. The list goes on and on and on. And so it can be somewhat overwhelming to have someone come in and say, we should actually be doing something else. Another barrier also can be what we believe to be already good oral health screenings. We were all taught in our respective educational processes to perform oral health exams and may feel that what we are doing is appropriate. Others of us may feel that we really don't have the knowledge that is needed in order to perform good oral health screening. Certainly, the oral environment is complex, and so we may feel that it's better served by someone else. And still others of us may feel that it's actually not our job to perform oral health screening. Certainly, going along with the last obstacle, there may be people that we feel are better suited for this. So if we go on to some of the lessons that I've learned in my time at the 1917 clinic, the first one is that implementation of oral health screening does require a clinic-wide commitment. One of the things that I didn't mention as an obstacle that I should mention is a linkage of care to an oral health provider. Certainly, that can be a challenge. And one of the things that I think is important is that oral health is championed by the leadership of the clinic. This is certainly something that has been evident at the 1917 clinic well before I got there. Certainly Dr. Hill is the director of the dental clinic. But also the leadership of Dr. Mike Sag and Dr. Jim Raper, they have always had a strong commitment to oral health. And they have implemented several things that have been very helpful to us as primary providers. And one of those things is didactic and practical training. Certainly the lecture that you just heard is one that is informative and also very practical in helping us to understand how to do a good exam. Other training, though, that we have received because of the leadership in our clinic and the willingness of Dr. Hill is information on HIV-related oral pathology, as well as appropriate triage and referral of the patient with oral health pathology in understanding urgent versus emergent need for referral. Another very important factor is close communication. Again, we are lucky to have Dr. Hill in our clinic. We are able to communicate closely with him on a patient-by-patient basis in order to understand how to treat appropriately when that is the right thing to do, and also when to refer the patient. I also think another important factor is, as we see witness benefit, there's buy-in at the individual and also the clinic level. So of course this, in my opinion, this is key, that there is buy-in from the whole clinic and there is a clinic-wide commitment to oral health screening. So these are more personal lessons that I've learned, and the first one is that my oral health skills really could be a lot better than they are, or were. Certainly there's a lot more to it than I was taught in medical school or remember being taught in medical school, and I think that this is evident by some of the ways that I have written my oral exams, and these are from my notes in the past and from my colleagues' notes, but a two-word description of the oral environment suggests that I may not have been doing an appropriate examination. As Dr. Hill has demonstrated today, there is a very systematic approach that can be taken to the oral health exam. And one of the concerns I know that we all have is do we have the time to do this? And it probably takes me about a minute to do oral health screening. But that's because it's systematic. Because it's systematic, it's efficient. And as I will try to convey later on in my presentation, it's also effective. Dr. Mofidi pointed out at the beginning of this webinar the important link between oral and systemic health, and they are in fact inseparable. As we all know, in primary HIV care, the mouth offers a significant amount of information about our patients, certainly about opportunistic infections. What I've learned is that in many cases that we are all able to recognize common presentations of common opportunistic infections, such as is demonstrated here by pseudomembranous candidiasis. However, through my opportunity to gain didactic training in HIV-related pathology, I've also learned that there are certainly atypical or less typical presentations of common infections, such as is demonstrated here by this example of erythematous candidiasis. Now, it doesn't say on these slides, but these slides are taken from hivdent.org, which is an excellent resource for photographs of HIV-related pathology. Something that I think is something very important as well, as far as understanding the link between oral and systemic health, is that the mouth can often give us evidence of risk behavior in our patients. As Dr. Hill pointed out, certainly meth mouth, other substance use can lead to changes in the oral environment. This picture is actually a patient that we saw in clinic who didn't notice that anything was going on in his mouth. But when oral health screening was done, there was this basically chancre from primary syphilis. So by looking in the mouth, we may be able to begin a discussion with our patients about substance abuse, about sexual risk behaviors, and potentially provide some sort of an intervention at that time. This is a picture of a patient who, for various medical reasons, certainly has poor dentition and a poor oral environment. And as we can all imagine, this certainly can interfere with our patient's ability to adhere to their antiretroviral regimen. In addition to poor dental health, certainly other manifestations that cause odonophagia, dysphagia, etc. can interfere with the patient's ability to take their medicines. Dr. Mofidi also mentioned the importance of nutrition, which is definitely related to the oral environment. And I don't think that we can underestimate the importance of pain and suffering associated with a poor oral environment in our patients. The next lesson that I've learned has to do with buy-in from myself as well as my colleagues. And so I want to share with you just two simple examples. This is a patient that was seen by a colleague of mine, an African-American male who was presenting with a new diagnosis of HIV. His viral load was 120,000. His CD4 count was 126. And when he presented for his initial provider appointment, his physical examination was normal except for this. And somebody brought up the question of KS earlier. You can see this area right here. Well, as we all know, in persons with darker pigmented skin, they can have variations in the color of the mucosa and the skin. But this provider had actually been to Dr. Hill's lecture 1 week prior and recognized that this area of pigment change was in the posterior hard palate. It was non-painful and it was purplish brown. He was able to get the patient into an oral health provider that was able to biopsy the sample, which was in fact Dr. Hill. The patient was diagnosed with KS, treatment was begun, and certainly the patient is much better off because it was an early lesion rather than waiting to a later, until the KS was much more evident and having to deal with it at that point. A patient that I saw in clinic was actually in this last year is a Caucasian male who has well-controlled HIV. He is on AAA, or efavirenz FTC TDF. His HIV viral load, when I saw him, was undetectable, and his CD4 count was 535, so very well controlled HIV. And he came in to see me for a routine visit and mentioned that he'd had some sore bleeding gums for the past couple of days, but wasn't too worried about it. When I looked in his mouth, though, what I saw was this. I saw concerning evidence for acute necrotizing ulcerative gingivitis, which, as Dr. Hill mentioned, has a rapid onset, can lead to interproximal gingival necrosis, certainly pain, bleeding, and halitosis, and most concerning is if it goes untreated to significant tooth loss and pathology. Fortunately, we were able to get this patient in again to see Dr. Hill, who provided the appropriate intervention, and the patient was able to keep his teeth. Finally, the last lesson I've learned, and this has come after continuing to do oral health screening, is really that it is my job. As the primary provider, I am not only the first line, I may be the only line for this patient. And in fact, many of our patients don't see an oral health professional of any type, and so it is I believe strongly, our responsibility to screen our patients. And so let me end with this slide. I really do see the primary provider as the front line and at the center. It's not necessary, in my opinion, that we become oral health pathologists or specialists, but we are able to screen and determine normal from abnormal. We can use this information to identify and diagnose when we feel comfortable with the diagnosis and determine a course of action. For example, we can treat our patients if we feel that we have the knowledge to do that, and hopefully, and I know that this can be a struggle in many environments, but we have the ability to refer our patients to the appropriate person in order to improve their overall health. So that concludes my presentation. Thank you very much for your time.
And thank you very much, Dr. Van Wagner, for that informative presentation. Everyone, we have a few minutes to ask questions, directing them to Dr. Van Wagner. And so we have the first question from Helene Bednar. Do you inform patients of the importance of disclosing their HIV status to their oral health care providers?
Yes, I think that is of critical importance, and sometimes it can be a challenge. Certainly there are environments where, and still some misinformation where, and we do hear from patients at times who have experiences that are suboptimal. However, I believe that it's very important for the patient to let their oral health provider know about their HIV, certainly because, as Dr. Hill mentioned, there can be manifestations specific to HIV. Not only that, I think that it's just as I want to know about all of my patients' medical oral health problems, I would feel that an oral health provider would also want to be informed of all of their patients' medical issues as well.
Mm-hmm. Thank you very much. Dr. Van Wagner, as others try to pose their questions, I have a question for you, and you talked about leadership. How do you obtain and elicit that leadership buy-in in doing screenings or health screenings in a medical care clinic?
Yeah, that's a great question, and you know, Dr. Hill and I were talking about this earlier. We have been fortunate that we work in an environment where that has been championed by the leadership. I think that one of the policy, certainly with what is happening through HRSA and through other organizations, is key to have policy in place that certainly points out its importance. I think that another key feature is simply education. For example, starting from maybe if if the clinic is starting more from a grassroots sort of a situation, it may require initiating oral health screening and education about potentially the benefits that you see in your patients through that. I know that, and I probably shouldn't speak for Dr. Hill, but I know that one of the things that he tries to do, and he is a resource for medical providers and also dental providers outside of UAB system. And so sometimes it's helpful to bring in someone to try and talk with the leadership or inform the leadership as well about the importance of this. Dr. Hill may have something to add to that. No? Okay.
I agree.
And maybe something, we have a participant who has echoed what has been said up to now, that they're always after their MD to ask his patients when they had their last oral exam. So there's another question here, and that is, can you discuss wasting syndrome and impact on oral cavity and need for referral for this?
Sure. So wasting syndrome. So it's kind of one of those catch-22s, I think. Certainly, wasting syndrome is something we see in advanced HIV, sorry, I'm seeing a couple of different things on the screen, excuse me. So wasting syndrome certainly is of key importance in our patients, especially with advanced HIV, and the oral environment can play a significant role in that. For example, the pain associated with thrush, the pain associated potentially with eating. Some of the things that I do, and if Dr. Hill wishes to comment, he can, but certainly in the process of treating whatever is going on, we need to be cognizant of the potential pain that is associated with eating. And so things such as viscous lidocaine are often helpful for our patients in order to help them eat. Even education, if we're lucky enough to have a dietitian, if we're not, but foods that can be tolerated that have high caloric intake but are relatively easy to swallow, I think can also be helpful. Certainly for patients who are in this situation, when possible, getting them in to see a dentist earlier can also be helpful to improve their oral environment to such a point where they are able to eat better.
Thank you. And just one question, and maybe if you can address it in less than a minute,
Okay.
and that is that for some medical providers who are not in an academic setting like the ones you're at, do you have any suggestions, any thoughts about how to go about making finding a dentist, making a referral to a dentist?
Sure. That is a really tough question in some ways to address because it does take potentially a little more or a lot more work. Certainly the question is how to identify those individuals. I think that two things are being done. I know that in the medical as well as in the dental professions, there is a significant effort to educate dentists about HIV in order to improve their comfort level as well as the patient's comfort level with their care. I think that it's going to take the primary providers contacting dentists in their area and finding someone who would be willing to see their patients, and as simple and also as difficult as that.
Well, thank you very much, Dr. Van Wagner. We are going to move on. Well, we have a poll question, number 4, and we will see this in a moment.
All right, poll number 4 is now open.
And this is addressed to dental professionals. What proportion of your patients are HIV infected?
Okay, the poll is now closed.
Wow, one thing that really jumps out is that almost 33% of the dental providers on this webinar have anywhere between 11% to 24% of their patients who are HIV infected. Why don't we move on to our next presenter. Last but not least, I would like to introduce Ms. Susan Richardson, who is with the Southeast AIDS Training and Education Center, and she has been instrumental in HIV/AIDS clinical education for more than 15 years. And we have invited Ms. Richardson to give us a case-based talk to illustrate how attention to oral health made a difference in a patient's overall health. Susan?
Hi, thank you, Dr. Mofidi, and thank you, IAS-USA, as well as the NRC of the AETC. Thanks for inviting me to join you. Can everyone hear me okay? I want to make sure, just type a little something in the chat room if I'm not coming out loud and clear. I have been a nurse practitioner in HIV/AIDS, as Dr. Mofidi said, for about 15 years, so I've worked in a number of different types of clinic settings. The case I want to share with you is a patient that I had when I was in a rural setting in northeast Georgia. Josefina is 26 years old. She presents for a sick visit, so she walks in, which is not easy for her because she lives some distance away. But she did get a ride. She's got mild throat pain and sort of a scratchy sensation. But more than anything, she feels like there's something stuck in her throat, and she's unable to swallow her food or pills. Presently, her CD4 count is 132, and her viral load is 6,700. She began atazanavir, ritonavir, and fixed-dose combination tenofovir and emtricitabine about 1 month ago. And at that time, before starting antiretrovirals, her CD4 count was at its lowest at 96, and her viral load at that time was 123,000. She had had PCP pneumonia 1 month before starting her antiretroviral therapy, so we knew that she had a diagnosis of AIDS even just without her CD4 count as it was because of her history of OIs. On exam, she had no temp. Her oral exam was unremarkable. I was really looking for thrush or any other lesions, but particularly because of the way she described her food, feeling like there was something stuck in her throat. Her lungs were clear, heart and abdomen were within normal limits, and she had some tender anterior cervical nodes, about 7 millimeters, symmetrical, smooth, round, and mobile. Also, her other labs that I needed to look at because of, making sure she's not having bleeding issues or anemia, her hemoglobin was 11.2, her crit was 32.4, white blood count was 2.9, her absolute neutrophil count was 1,500, and her platelets were 130,000. Now, I felt pretty sure that although she did have no oral thrush, that she had esophageal candidiasis based on her complaint and her symptoms. So per the OI guidelines, I treated her with fluconazole, 200 milligrams every day for 3 weeks, and I asked her to come back if she could in another week. Well, before she made it back for her appointment, she came back a day early, actually 3 days early, to tell me she had had no relief of her symptoms, and now her pain was retroexternal. On exam, again, she was afebrile, and this time I saw a very small 5 by 5 millimeter shallow ulcer. It was kind of red and very tender to touch with a swab. So at this point, I sort of started thinking about ulcerative lesions that may also be in the esophagus. So I thought about HSV. She denied any history of syphilis, denied any history of oral or anal sex, and When we do intakes on our new patients, we don't do HSC serology. So I didn't know if she had herpes or not. And I couldn't get one then because we just can't afford it. So her differential diagnosis to me was herpes or CMV, which is cytomegalovirus, and maybe other viral ulcers. To diagnose the CMV, an endoscopy would be required. And this was obviously not an option because of the cost. We just couldn't cover it at the clinic. So I swabbed the lesion with swab and sent it for herpes culture and put her on acyclovir 3 times a day for 10 days. Well, 3 days later, she calls and reports still no relief. So at this point, I'm thinking, what did I miss? Why is she not getting better? And now that you've heard the story from Dr. Hill, you know that herpes lesions usually appear on fixed or keratinized tissues. So I sort of completely missed the boat there. And while I had her on the phone, I looked for the culture results, and they were negative, although, herpes cultures aren't real great on sensitivity or specificity. So, I didn't feel really sure one way or the other. But I told her to stop the acyclovir and start a new prescription. At this point, I thought maybe some steroids would begin to help and have her come back in the morning. So I prescribed dexamethasone elixir, 5 cc's, swish for 1 full minute. This is 3 times a day. Leave it in the mouth for a full minute, and I asked her to kind of gargle with it a little bit if she could, and then spit it out. Well, she came back in the morning, and this is what I saw on her exam. She had this larger 1 by 1 centimeter lesion, and now it was extending kind of downward into her larynx. I couldn't really see the edge of it. Now with a yellowish pseudomembranous covering, and it had this, let's see, maybe if I can, nope. This erythematous halo kind of around it. So at this point, I called for help. I wasn't sure what I was dealing with. If it was an abscess ulcer, it was the biggest one I'd ever seen. So I was able to get in touch with our Part A dentist, a couple of counties away. And he also happens to be an HIV specialist, so I was felt like I was getting the best consults I could. He said that it was probably severe abscess ulcer and advised treatment with systemic steroids at this point because the dexamethasone just wouldn't clear it. Also said to have the patient follow up with an experienced dentist. Now, the one we had access to was in a community health center, which was 2 counties away from where Josefina lived. So at least in a week or sooner if she did not improve on the oral steroids. So I gave her a script for tapering prednisone, starting with 60 milligrams, tapering down to 10, and I also gave her a prescription for pain relief, viscous lidocaine. I was really concerned because though she said she was not skipping her doses, I'm not sure she was able to get it all down, her antiretroviral meds that she took in the morning. So hopefully this would help relieve some of the pain and let her be able to get, some nutrients in as well as her meds. I asked her to come back in a week and gave her the contact information for the community health center dentist if she got worse. Okay, so 3 days later, on day 12, so finally she's starting to feel better and tolerating soft, bland foods. I recommended I gave her some Ensure to take home and recommended that she try some bananas, applesauce, and rice, and she was getting that in. Came back to see me, as she said she would after starting the prednisone. The lesion was completely gone. I was glad to see, and I asked her to keep hold of this information so that if this does come back, either in the same manner or in a different fashion, or she developed any other oral or dental health problems, to get in touch with them and see if she can get herself there. So basically, I will try to tie this back into the title of the case, which is a hard pill to swallow. It was tricky. Well, obviously, Josefina was having trouble swallowing, but also it was a bit tricky for me because I think my medical sort of the way I was medically interpreting her symptoms led me to believe it was something more than just an oral health problem, when in fact it was a simple problem that if I'd known what it was, I could have treated it sooner. But we worked very hard, had her come back to the clinic 3 different times, and finally got her to feeling better so that she was able to get back on her regimen. Thank you very much for your participation. And Dr. Mofidi, back to you.
All right. Thank you very much, Susan. At this time, we'll take some questions. And a question that came to my mind, Ms. Richardson, was that were there any opportunities that arose that you thought that could have been good opportunities to provide some oral health counseling education to this patient?
Yes. And quite honestly, her oral health cavity looked pretty good. She had had thrush earlier when I had seen her. Yes, but I did. I sort of, especially in terms of the pain she was having, to make sure she kept everything very clean. I was afraid to tell her to go with Listerine or something in terms of, hygiene and antibacterial, because I thought it might burn. But I did ask her to keep her mouth as clean as she could, and rinse very well.
Yes. There's a question that has been posed. Did you consider using thalidomide?
Well, that's a very good question. And I know that it has been used to treat severe acid ulcers. Unfortunately, it's not real available. So I did not think that I could get it for her in time. The pharmacist would have had to order it, and that would have been probably a big roadblock. So I was just hoping that the oral prednisone would do it.
Dr. Mofidi?
Yes, Dr. Hill.
Dr. Hill, if I could comment on that. I've been watching the comments in the chat room. I have used thalidomide in a couple of cases, but the issue with thalidomide is that it is very well known for causing birth defects, and so it should not be used in females, especially females that are still of childbearing age. And it is very highly controlled, so you have to have special prescribing, you have to have special permission, special privileges to be able to even prescribe it. So the only cases I've ever used it in were in refractory giant aphthous ulcers in males, and it actually did work quite well.
Dr. Hill, while you're on the call, there was a question directed to you earlier, and that had to do with what fungal medication you prescribe for angular stomatitis.
Well, any topical antifungal cream would be fine. There is a particular one that I don't want to mention any brand names or anything, but any topical antifungal that can be applied directly to the lesion 3 to 4 times a day for at least 10 days, maybe 2 weeks, depending on the severity, should work just fine.
All right, thank you. And there's one other question. Would you be concerned about using steroid given patients suppress immunity for Ms. Richardson?
Yes, that's a very good question. And steroids actually work very well for some of my patients, and it's such a short blast. The tapering lasts over 5 to 7 days, and it really it really packs a power punch to the inflammation without being in the system for so long that you see a drop in the CD4 count or a rise in the viral load.
Very good. Questions coming in, but I think these are more comments about nystatin cream working just fine on angular cheilitis. And will there be another webinar to cover oral health in infants and children to be consulted on? we don't know yet, so it's part of our follow-up conversation on our next steps. So thank you, Mary Brown, for asking that question. It looks like there are no more questions. Okay, why don't we go on to our last poll question, poll number 5.
All right, this poll is now open.
And this is directed towards the primary medical providers. Having participated in this webinar, will you increase oral screenings in your patients?
Okay, this poll is now closed.
And we have a great response. Yes, more than 50% of the participants have said that they will increase the oral screenings with patients with HIV/AIDS. So that's great news. So we are almost at the end, and I wanted to thank all the presenters for excellent and very informative presentations. We started this webinar by pointing out that oral health is essential to overall health, that oral health care is one of the most frequently reported services needed by persons living with HIV but not received. It is clear from our presentations that primary medical care providers are positioned well to make an impact on the oral health of people living with HIV/AIDS. We focused on how to conduct oral health screenings. Dr. Hill gave us that presentation. And then we heard about lessons learned on the implementation of oral health assessments in the primary care settings. Thank you, Dr. Van Wagner, for that presentation. And finally, Ms. Susan Richardson, she gave us a concrete example on how attention to oral health in the office and interprofessional collaboration with a dental provider made a difference in a patient's overall health. So the potential benefits of this type of model of care on oral health and overall health is extremely promising. We wanted to leave you with some related resources. There are resources that are mentioned on this slide: AETC National Resource Center, HIV Dent, HIV Insight, and Guide for HIV/AIDS Clinical Care. And again, I would like to thank our 3 presenters, Dr. Hill, Dr. Van Wagner, and Ms. Susan Richardson. I'd like to thank all the attendees, AETC National Resource Center, as well as IAS-USA, and finally HRSA to put together this presentation. I would like to remind everyone to fill out the evaluation and CME claim form. They can find this information on the link in their email reminders that they received today. Please take time to fill out the evaluations. We serve your needs by you letting us know your thoughts. And as a reminder, this webinar will be archived on the National Resource Center and the IAS-USA websites, and information on where to find these websites will be emailed to you within a week. So with that, again, thank you very much, and we look forward to having more of these presentations on oral health and HIV/AIDS. Thank you.
Thank you so much. Have a great afternoon, all.